Okay, good afternoon, folks. This is Ken Crandall, the current president of the board, welcoming you to the Seneca Healthcare District Board meeting for today, May 27. I'll call the meeting to order at 3:01. Attendance for board members, Dr. Walls.
Here.
Okay, Jerry Nielsen,
Here.
Rich Rydell.
Here.
Thank you. And Kristen Montgomery.
Here.
Thank you. Everyone is present. I'm Ken Crandall and present as well. Join me in the Pledge of Allegiance, please. I see the boardroom has the flag in it, so. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, that takes us to item number 3 on our agenda, which is the public comment period. We have some people who called in, and so I'm wondering if there is a public comment that someone would like to make.
And we don't have any public participants in the waiting room here. I am getting one person from the Zoom waiting room, but at this time I have no hands raised.
I show Karen Turner is waiting and Elizabeth. I guess you're admitting them right now.
Correct.
There we go. Okay. That said, I just want to give a little advisement, and I call this to Jerry's attention. I think Jerry's aware of this. I am unable to attend the board meeting. I was planning to come today in person, but my wife is in Chico with doing babysitting duties for a 2-year-old granddaughter. And I'm home alone with a puppy or dog who just got out of surgery. So I'm hoping she doesn't get in distress or something. But Jerry, if you don't mind, if I have to step away, I'll let you know.
Sounds good. Thank you, Ken.
Okay, thank you. Okay, guess there's no public comment beyond that. Board members, public comment? Okay. Then let's move on to item number 5, which is the approval of the minutes from our May 7th meeting. And board members, if you've had a chance to review that and you have questions or concerns about the minutes, now is your chance to speak up.
Do you want a motion to approve both of them together or separately?
Separately.
Separately.
Yeah.
Oh, that's right. We have 2 of them here, April 29th. Let's do it separately just to be safe. And I have a motion to approve the minutes for April 29th.
I'll make a motion.
I'll second this, Jerry.
Okay. Okay, Rich, your vote?
Aye.
Okay, Kristen?
Aye.
And Jerry?
Aye.
And Dr. Walls?
Aye.
And I will vote aye as well. Okay, so let's take the special meeting from May 7th. Need a motion and a second.
I'll make the motions, Jerry.
Jerry?
I will second, Kristen.
Okay. Okay. Rich, your vote?
Aye.
Dr. Walls?
I'm going to abstain. I was not at the meeting.
Oh, yes, correct. Thank you for that. Okay. Kristen, your vote, you made the motion, the second. Okay. Rich?
I was not at the meeting either.
Oh, that's right. So there's Jerry, Kristen, myself. So we have, I will vote aye. And so let me go back to Kristen
Aye.
and Jerry.
Aye.
Thank you. Thank you for reminding me that you weren't there. That takes us to the med staff report. I believe I saw Dr. Cooper's name flash on the screen. We're being asked to approve the reappointments from 2 practitioners from Allied Health, and 3 people were their reappointments from the medical staff, the telemedicine program. So any questions about these for Dr. Cooper? Anything you'd like to add, Dr. Cooper?
No, I don't have anything to add at this time. Can you hear me?
I can hear you. Thank you.
Oh, great, thanks.
Okay, I would take a motion to approve, well, this is the same person, Munjar, Aaron Munjar. I'm not sure I understand why we're doing 60 days and 2 years.
That would probably be a question for Joanne. I think we had to get in sync or something, so she did the 2 months and then wanted the 2 years after that.
Okay, I don't know if Joanne's on the line with us or not. I don't really, my sense is it doesn't make much difference if we just approve both of them.
Right.
Well, the 60 days is just temporary privileges. The 2 years is beyond that.
So they don't run concurrently then.
No,
Okay, so can I have a motion to approve the 60-day reappointment and the 2-year reappointment for Aaron Munjar?
I'll make a motion.
I'll second, it's Jerry.
Yeah. Okay, and Rich, your vote?
Aye.
Okay, and Kristen?
Aye.
And let's go back to Jerry.
Aye.
Dr. Walls?
Aye.
And I will vote aye as well. Okay, and now we have the reappointment of the telemedicine psychiatrist and a couple radiologists here. So this is Kovacs. I'm not sure I'm going to pronounce these right. Jay Donahue and Setsu. Sorry if I butchered those names. We're asking to, the first one to reappointment for 60 days, the subsequent 60 days, and the latter two for 2 years. So can I have a motion to approve those items?
So moved.
I'm sorry, who was that?
Dr. Walls.
Thank you, Dr. Wells. Second?
I'll second, it's Jerry.
Okay, and Rich,
Aye.
Kristen,
Aye.
okay, Jerry,
Aye.
Dr. Wells,
Aye.
and I will vote aye. Okay. Dr. Cooper, does that take care of the med staff stuff?
I believe it does. Thank you.
Okay, thank you. We have policies and procedures on item number 7. We're going to vote to approve the policies identified on your agenda. I'm a little confused. The board will vote to approve the following policies and procedures approved at May 11th. So the language there is a little redundant. Can somebody help me out with that?
So, yeah, I just had a question about the skilled fluid policy, because it looked like there was a change made to the policy itself, but the item was not made to the form that the nursing staff fill out, and I didn't know whether that needed to be modified or not.
Sean, Jerry, I'm still confused by the language here in the sentence here that says, we're going to approve the following policies and procedures that are approved. Oh, these were from the med staff. I'm sorry, that was just my error. Okay, go ahead, Jerry. Can you restate that, please?
Yeah, is Ashley on by chance?
I'm sorry?
It doesn't appear.
I don't think she is. I did reach out to her earlier today to bring up her question.
She's here. She's trying to talk. She just walked into my office, Sean. Hold on.
Thank
Go
you.
ahead, Ashley.
Sorry, I hit the button. I cut off the phone. Anyways, there is a line item. We're not opposed to adding that, but it wasn't added because it's an e-form and we'd had to go through IT, which I didn't go through. And the last line item on that form says other, and please indicate. So it's up to you guys. We can add it or we can just do the other as the indication.
I just didn't know if it was maybe something that needed to be kept track of, and be able to be reported on. And so I just wanted to bring it up for that reason.
If for better clarification, I mean, to dot our i's and cross our t's, we probably should add it.
So are we gonna approve that policy now as it is, and then you guys will modify it, or do you want to modify it first?
I would like to approve it and then make the changes after, if that's okay. Because the policy is changed and everybody's approved that, and it's just the E form that needs to be updated.
I think that makes sense. So Ken, I'll make a motion to approve the policies and procedures listed on the agenda 1 through 4, and thank you for that information, Ashley.
Okay, so Jerry, I'm sorry, I kind of lost track of, are we talking about one of these which one of these policies on our agenda were you referring to?
Number 3, sorry about that.
Okay,
But I'm making a motion to approve all those first 4 now, because they're just gonna make that minor change and then bring it back.
okay, so we're looking for, these are policies and procedures identified as 1 through 4 on the agenda. The medication administration policy, the residential emergency care visit, fluid policy for SNF/LTC unit, and an admin contract review and approval and business associates agreement policy. So we're talking about all 4 of those. And who made the motion?
Jerry did.
Okay. Do we have a second?
I'll second that, Dr. Walls.
Thank you. Rich?
Aye.
Okay. Kristen
Aye.
and Dr. Walls
Aye.
and Jerry.
Aye.
And I will vote aye, so those policies have been approved. Now we have some additional policies and procedures, 5 and 6.
Yeah, Ken, I'm gonna ask if we can table those, because I think we need to work on them a little bit more. These are ones that legal had provided to us when we were changing our bylaws.
Mhm.
And they need a little bit more tailoring, so I'm gonna ask if we can table those 2 for this meeting.
Okay.
Who's going to work on it? Are you going to do it?
I'm gonna work on it, and
Okay. Any objection to putting this over to our next meeting?
No?
Okay. And we'll table those for the time being. Okay, and that takes us to item number 8, and I'm assuming Steve is with us for the financial report for April.
Yep. Hello, everyone.
Hi, Steve.
Okay. So we're talking about the month of April 2021, which is the 10th month of our fiscal year. So for the month of April 2021, we are reporting a net loss of $486,000 versus a budgeted loss of $386,000. The loss was almost entirely attributable to a negative variance in operating expense, specifically in the, or mainly in the area of salaries and wages. And what we did in the month of April, we reached an agreement with our union about a wage adjustments for calendar year 2021. We did adjustments related to moving the minimum wage and what Jim Koyman calls compression, which means that when we move a department that bumps up against the minimum wage, that it moves some of the other departments around them so that our scales are adjusted so that departments that get bumps on the minimum wage don't pass up other departments where we want to have a wage separation there. And this, then we also gave 1%, a minimum of 1% to all employees with the exception of the C-suite. And this adjustment was retroactive back to January 1st. So other than that, our FTEs were in line for the month, and our average hourly wage was a little bit above budget, and our contract labor was over slightly. We had a slight variance in our FTEs and contract labor. Supplies were over budget. We continue to have some COVID-related expenses in the testing supplies. We continue to utilize IV therapy drugs, and we made some enhancements to the patient rooms by installing new whiteboards. So any of you guys that have been in the hospital or visited a loved one in the hospital, you see the whiteboards where it says today is Thursday, May 27th, it's sunny and warm, and your nurse is so-and-so. Anyway, we've done all of that, and so otherwise there was a fairly benign month. The revenue was slightly above the budget that we created. It's, if you want, for lack of better terms, it was a COVID budget. We budgeted for what we expected to see in revenue during this time. So we exceeded the gross revenue by about $59,000. We continue to have some adjustments related to non-billable COVID testing, mainly the surveillance of our employees and other contract tracing that we do, which is fairly minimal right now, thank goodness. So the net patient revenue was positive, about $14,000. Our clinic utilization is well below budget. We unfortunately, when I did the budget, I did not adjust our visits down, but we had 685 total clinic visits versus a budget of 892. During the treasurer's meeting, we talked about the relationship to previous months, previous years, same month, April 2020, April 2019. As I note in my narrative, April 2020 was the second month when in the first full month that we were experiencing the impact on operations in our facility related to COVID, not necessarily that we were experiencing COVID cases, but the infection control measures that we took definitely impacted revenue and just the general public concern about going into a hospital at that time when we were just in the beginning stages of the pandemic. So we did do better than April of 2020, but we're still way below pre-COVID revenue and utilization. April of 2019, we had 1,050 clinic visits versus 710. So that's really where, as we go into the next year and we start trying to project budget and what we can do, that's really where the change needs to happen, is we need to determine ways to drive patients into the primary care setting, which then feeds the rest of the hospital. The ER emergency room visits for April, and then we went ahead and looked at May, but April of 2021 is a little bit below pre-COVID, April 2019. So the ER visits, the ER utilization is starting to come back. It's the primary care where we continue to lag in bringing back our utilization and in turn our revenue. May looks pretty similar. Our ER utilization is up, but of course in May of 2019, as people start coming here, the visits went up, but our projected visits for May in the ER are going to be just below 2019, but again, our projected visits in the clinic are going to be well below May of 2019. We did have a drop in cash And as I note here, it's related to cash on hand, related to three things. The loss for the month, of course. We had 3 paid payrolls. I don't know the grammarian in the group, if that's proper way to say it, but we paid 3 payrolls, which run about $300,000 each. So an additional $300,000 on our cash flow. And then we made our rate range IGT of $968,000. And we should be seeing, we anticipate we'll receive around $3 million back in a supplemental payment on the rate range, and we're hoping to receive it by the end of June. Not reflected here, but in the month of May, we also made a final IGT on the Prime program. We were not sure if there would be money available, but they did distribute some money, and we sent out, sorry, I didn't write it down. I believe it was 200 and rough numbers, 250,000. We're going to get 500,000 back. So again, our cash position remains strong, and it's going to be even stronger when all these payments. So we should end the fiscal year in a nice cash position. But when we get done with this, I'll just talk briefly about the budget for 21-22. So any questions or comments or anything about the financials for April?
Hey, this is Jerry. Are we expecting to get that Prime around the same time at the end of June?
I'm expecting that money anytime, like any day kind of thing. They were scrambling to get it done so they could close out the program. So I'm just thinking we could see that at any day.
Okay.
But absolutely, I think they have to pay it by the end of the year so they can close out their state fiscal year. So that one we'll see for sure by the end of June.
Great, thank you.
Other questions? Okay, I guess I'd look for a motion to accept the April financial report.
So moved. This is Jerry.
Jerry, okay. Second?
Second.
Okay, Rich, that was you, right?
Yep.
Okay. Dr. Walls?
Aye.
Okay. Rich,
Aye.
Kristen,
Aye.
and Jerry?
Aye.
And I'll vote aye, so that carries. Okay.
Hey, so Ken,
Yeah,
so while we're under this section, I'd just like to real briefly say we're in the process of preparing the budget for fiscal year 21-22. And as I mentioned, the biggest challenge we have right now is trying to project out revenue because there's not great signs of encouragement that our revenue, at least at this moment, will grow. So we're trying to be reasonable and conservative at the same time, and it's providing some challenges. So what I would like to do is, and we have a really short month in June. I think we're meeting on the 24th or 25th. The last day of the month is a Wednesday, so it's a short month for board meeting wise. So what I'd like to do is I'd like to have a whatever you want to call it, special meeting, treasurer's meeting, finance committee meeting on June 11th or June 14th to present the budget to you all, because I want to go through it in detail, and I want to spend time on it, and I don't want to take up an hour and a half of a board meeting if we can avoid it. So how does the board feel about that?
so Steve, I just noted the dates you mentioned. I can't do the 11th, but I can do the 14th.
Okay. Rich, do you have your calendar in front of you?
Yeah, that week is not, I would have to do it remotely.
That's okay. You could do the 14th though?
Right, I can't do the 11th, I can do the 14th.
Okay. Okay. So I don't necessarily want to canvass the rest of the group, but what we'll do is we'll go ahead and if we do it on Mondays for the rest of the group, is any time on Mondays good or bad for you all, Jerry, Kristen, Dr. Walls?
I can make it work, whatever works for everyone else.
My preference there, Steve, would be later as 3 o'clock or later.
Okay. So if we started at 3, we would get everyone out, I'm not trying to scare you, we'd get everyone out by 5, so like normal end of your day. So I'll go ahead and we'll just send that invitation out, or however we got to do it will be a public meeting. So however we need to do that to stay straight with the Brown Act as far as sending out invitations to you all or whatever.
We'll just need to do it as a special meeting.
Okay. So that's good. I think it's just good. We're going to have a pretty solid budget. It's probably not going to be one that's going to, make you feel great. I mean, we're trying to basically get it to a break-even cash flow wise. So the way we do it is we have a net income loss, and then below the operations is the IGTs we have to transfer. So if we can get it to a break even, that's kind of our objective right now. And so we'll.
I just had
Yes?
I'm not sure if it's a comment, question. For me, and I don't know if it becomes part of the discussion on the 14th, but the point of discussion that I'm curious about is, what can we do to turn this around, and what strategies? Maybe it's a Sean question, maybe it's for both of you, but that's the conversation I'd like to have.
Yeah, absolutely. There will be a strategic element to it, because maybe between now and the 14th, there's things that we can, as we start to say, well, what revenue can we realistically grow without, having to be funny with the numbers. But one other thing to keep in mind is that this year is unique, and maybe it gives us a kind of an education on life without the supplemental payments. For this fiscal year, we're transitioning the Prime Grant program to what's called QIP. And because of that transition to the new program, we'll go through an entire fiscal year without any payments. So a normal year, it can go up and down, but generally we get a net $750,000, $600,000 to $750,000 out of that program. So we're getting hit with that. Now, two of the one big program, Rate Range, and the other one, HQAF, they're going to go to a calendar year payment model. And so it appears that we'll only get half of what we normally get net. So, I mean, these are multi-million-dollar hits to us. So when you add them all together, so that's the other complication of the budget. But still, it doesn't diminish the need for us to grow the revenue,
Right.
because there's bigger issues than a balanced budget at play here. So noted, I guess.
Okay.
All right, that's all I have.
Okay. Other questions for Steve from board members? Okay, moving on to item number 9, board meeting status. Sean, I'd just, I guess, like to open up this discussion and see if you have a recommendation at this time.
I recommend that we follow the California rule about June 15th, opening things up. I think that we're safe from a regulatory or legislative perspective to open up June 15th. I'm going to recommend that we start to come back together.
Okay. I would just put a contingency on that if something happens, unlikely, but if something happens that we don't make these modifications that were anticipated statewide on the 15th, that we could revisit it.
Yes, we can. And, I think that as we open it up to the public, we're very cognizant of the fact that some folks have not received vaccines and they're certainly welcome to wear masks, and it's not an issue.
Okay,
But we'd certainly like to begin opening it up and getting the public back.
Will we
very good.
continue that with the Zoom so people can join
We are going
otherwise?
to continue with Zoom, yes.
All right. Other comments, other members? No?
I think it'll be nice to have everyone back.
Agreed. Okay, so can we have a motion? I guess this requires a vote. That we will move back toward regularly scheduled meetings in the boardroom starting in June.
So moved, Ms. Jerry.
Okay.
I'll
Second?
I'll second that. I'm not
No?
sure we need to make a motion, but I'll second.
Okay, Rich, your vote?
Aye.
Okay. And Kristen, your vote?
Aye.
Okay. Dr. Walls
Aye.
and Jerry?
Aye.
And I will vote aye, so that carries. And that concludes our items on the agenda that require action. Moving into the information only component of the agenda, HRG, item number 10. And I'm thinking this is Steve.
Yeah, okay. So, we're looking at the month of April 2021. And you know what they say about excuses? Everyone, they're like noses. Everyone has them and they all smell. But we got a bunch of excuses this month. So, a couple things that happened was in the Medicare, two things went on. One is that we've had a swing bed patient in there. We had a swing bed patient in there for an extended amount of time. The outstanding balance was over $100,000. This is not unique. This does happen. Patient was ultimately transferred into our long-term care unit. So that AR builds up, and we don't bill it until we discharge the patient. So the other thing that happened was there's a thing called sequestration, cute name for taking money from you, is what Medicare does is they take 2% off of your payment. And it's just a way to cut the Medicare spend. Well, during COVID, they put a freeze on the sequestration, and so we were getting 100% instead of 90% of our payment. Well, the thing that extended or established the freeze on the sequestration expired, and Congress had to reapprove it, but Medicare didn't want to start paying claims at 98% and then have to give back the money. I think that's pretty much everyone said this is going to happen. It just has to go through the bureaucratic process. So as you can see there, Medicare held all the claims for discharges after May 1, and then it was approved on April 1, and was approved on by Congress on April 14th, and then the billing began back in the month. So a couple of things drove our Medicare AR days. In Medi-Cal, the big thing driving our Medi-Cal days was that we've had some additional placements. We are now up to 14 residents in long-term care, and even if individuals have Medi-Cal, we have to get them approved for Medi-Cal long-term or converted to Medi-Cal long-term care, and that takes a while to get the authorizations. That's what they refer to as the TARs. And so I think today I saw where we got all of our TARs approved. So we should probably see, we've had some approvals, but the bulk of them came through, I believe, today. So we should see maybe some reduction on Medi-Cal, but all that new revenues going into the AR and the existing. So we might have to ride this out for another month. But those are the two big things. We continue to do our darndest to work with HRG and hold their feet to the fire, and it's a never-ending challenge.
Questions, folks? No board members, questions? No?
No,
I don't have any question. My only comment is I admire Steve working on that.
Yeah. Okay.
Well, I appreciate that, but if I could, I also have our revenue cycle coordinator, Sarah Lynn, that's a first and last name, sitting here with me. So Dr. Walls, I'm gonna give as much of that nice comment to her as well. I mean, so thank you.
Sarah.
Yep. Thank you both.
You're welcome, Dr. Wall.
Appreciate the information. Okay. We can move on to item number 11, Strategic Planning Committee update, and that's Sean. And from there, we can move into the CEO report.
Okay, 11, Strategic Planning Committee update. We're meeting regularly, updating in our strategic planning. And strategic planning means both the new critical access hospital build and the efforts moving in that direction, as well as our current campus activities. So I want to just hit on the new critical access facility. We are still in our land due diligence period before escrow close. So we have several things going on. There's been a legal review of the title report. Land survey is in progress. Our geotech is in progress. It should be expected to be complete by next week or the week after. Phase 1 environmental is in progress. We are in discussions with Chester Public Utilities and LAFCO around annexation, the requirements, and then our floodplain protection species survey proposal is to come. So we are well down the path of due diligence, and everything is on track in that regard. Zoning and general plan amendment. So there's been a lot of discussion. I think I discussed it last time in the board meeting, that there's been some confusion around how the property is zoned, what it's zoned for, promises made. There's just a lot of stuff that was that's been confusing. So we are setting a meeting along with Supervisor Brawl. Some of us are going down to see Tracy Ferguson, who is the director. We're going to be talking about how we move through this zoning process. We'd like to get a special use permit. That would be the path of least resistance for the property. But we may be also facing a general plan amendment, with the caveat that we're going to be pushing is that we need to progress rapidly in that general plan amendment. So once again, just working with all of our county officials in trying to move the land and all the requirements for the land down the path. At the same time that we're doing that, we have been preparing a budget. So there was a preliminary draft budget that was that came up to 68.5 million. That was the kitchen sink. That was throwing everything that could possibly happen at the organization level, including capital purchases for medical equipment. This was everything. And this will go through multiple iterations as we move through. Obviously, that's a large number, and we need to see it much lower than that, but I think it will get there. Once again, this is a preliminary budget, is something we need to be paying attention to. Our focus is going to shift a little bit in our strategic planning from going forward with our schematic design, which is going to be laying out the actual footprint and the moves within the footprint of the facility, to paying attention to our funding. Actually, we're going to be doing them simultaneously instead of in a series. So we are going to be really looking at our funding options over the next year and a half while we are doing schematic design. So there will be funding approval requirements for schematic design. But once again, we're moving into how do we fund this critical access hospital. In that regard, there's a few things that need to be shared with the board and the public here. You know, we are looking at all potential sources to include our federal Lift America bill, USDA lending, Lake Elsinore Foundation. So the Lake Elsinore Foundation is now is formed or forming. It's almost completely formed. That is, the Lake Elsinore Foundation has a vertical underneath that foundation that is for the critical access hospital for philanthropic or charitable giving. So we have the ability now as a 501c3, protected by a 501c3 entity, governing entity, to accept donations toward the critical access hospital. So that's part of, obviously, the foundational philanthropic activities that are necessary to building the hospital. Very important. And that direction. Now we have the vehicle by which we can do it. AB 1464, Assembly Bill 1464 could provide some relief. I just want to share with the board that 1464, and I'm going to be sharing this with the public as well in the upcoming town hall. The reason that, and it's probably replication, but the reason that we have to build the new critical access hospital is that Senate Bill 1953, which was the seismic requirement bill, basically states that all hospitals, critical access hospitals, all acute care has got to be seismically retrofitted by 2030. Our building cannot be seismically retrofitted. We are in an earthquake zone, unfortunately, with our being our neighbor to Lassen. This building, built in 1952, cannot be retrofitted. It just isn't feasible in any way. So by 2030, we have to build a new facility. We have to. So we don't have a choice. Either that or completely shut down. And that's kind of what we're facing. AB 1464 is providing potential relief, and that is there's been some lobbying going on and some of the bill that's coming in to provide relief to critical access hospitals, whether it's certain exemptions or changing the way that, or the OSHPD is kind of the governing body of the construction, changing the way that they categorize certain areas within the hospital. I'll give you an example. OSHPD 1 is extremely expensive. It's about $1,700 to $1,800 per square foot. That is the highest level of requirement by OSHPD. And for the most part, emergency departments, acute care onsets, acute care settings have to be OSHPD 1, where we can do OSHPD 2, 3, and 4 in other parts of the facility. 1464 is looking for relief for a full exemption from 1953, which we doubt will happen. That's the long ball. 1464 will, though, they are looking at possibly changing the OSHPD 1 requirements. So we could potentially build a hospital for less money if we change that all those OSHPD requirements. And that's where we're working with the California Hospital Association and some other advocacy groups to really push 1464 and see if we can gain any benefit from that. So I just want them to be aware that there is activity out there in the legislature around this basically unfunded mandate. And that's really what it is. And critical access hospitals are really, really hit hard. It's an unfunded mandate, so we're working on that. Public awareness and promotion. So we're really going to start sharing with the public the concept of the new critical access hospital. We're doing mock-ups. We've approved Aspen to do mock-ups so that you can actually see the facade, what it looks like on the property. We are going to start sharing with the community. We're going to start answering questions around this new critical access hospital. I am going to be sharing information about 1953 in our unfunded mandate requirement and the compression that is going to happen. And this, when I say compression, 2030 seems like it's a long ways away, right? It's 8 years, 7.5, 8, 9 years. But the closer we get to 2030, there's going to be a compression. The compression is going to be in the ability for labor to get labor to do things like this, and the cost of construction will go up considerably. So it is in our best interest as an organization, as a community, to get ahead of this, and that's what we're working for. So public awareness and promotion about the new critical access hospital and why we need to build is really going to start to happen, as well as being able to see things and actually see mock-ups. So we're pushing in that direction. That's been approved, and we're moving forward. I'll pause there. That's the new facility. Does the board have any questions or anything that's not clear yet?
Members?
The OSHPD,
Yes.
categorization, you said $1,800 per square foot is for what category?
One,
Category 1.
which is the majority of our acute side, everything acute. ERs, floors, labs in the acute side, imaging, which is a pretty big square footage. It's quite large. So that's probably one. Any other questions from the board before we move on to existing facilities?
Well, Sean, you had referenced an upcoming town hall meeting.
Right.
um,
June 7th
June 7th.
is a Tuesday, right? 10th, so Monday. There, yeah, so the Seneca Healthcare is going to be featured in the town hall. It's at the old theater. That's going to be an ongoing thing sponsored by the chamber. And we are being premiered in the next town hall. And I'm really hoping to be able to answer questions about where we've been as an organization, where we're going as an organization, and of course the critical access hospital build out, and provide the community some awareness.
Great.
All the things we have going.
Okay.
Okay.
Anything else, folks? Okay, Steve, I guess we can just roll right into your CEO.
Well,
report.
I still have existing facilities, Ken, so
Sorry.
I'll move right through these. Re-roofing starts in, I think it was 30 days. We're gonna start our re-roofing. We have a 45 to 60 day schedule. The campus painting will start June 7th. So we are beginning with that, and we're gonna look pretty scrubby for a while because we're gonna be doing all the prep first. So that's happening. The security camera project is approved. We're just waiting on some IT things. Clinic parking driveway repair is waiting for the device to be repaired, but it's going to begin in June. Campus cleanup, so the train car, this is our caboose, our train car out there that used to be storage is going to be moved. We have a proposal. It will be moved potentially starting Sunday. This will be probably a multi-day thing, but we're going to move that, and we're going to reassess that space for what is another mandate, and that is the requirement for 90-day PPE and disaster recovery. COVID has put a lot of extra burden on healthcare, including having to store in an environment that is protected and air conditioned and heated and cooled, the PPE necessary for at least 90 days. So we're going to be looking at that space, but I'm really pleased that train car is taking the train.
Where's the car going?
It's going to a local place that Ken Willis has decided that he wanted to do this, so that's great. Thanks, Ken. The flagpole's been delayed, and campus perimeter fence. Saw some of the maintenance folks out there today with their tape measure. So our fencing that's been torn down and broken down for all these years is going to be replaced, and we're on our way. Those are the things that are currently happening with the facility. It's great because the public is going to start seeing some real change, physical changes to the plant, along with all the other stuff that we're doing. So it's exciting. Okay. Any questions on those? And I want to thank the board for the funding approval to get all these things done. They're on their way.
Moving along, sounds good.
They're moving along. Yep.
Okay, so are we ready now, Sean?
Oh, we're ready now, Ken.
Okay,
So the CEO report, physician mid-level recruiting and retention update. So we went through a process where we had a couple of physicians that came and take a look at us, were very interested in us. Fortunately, one of the physicians that actually came here and toured the area, really loved the area. It was between us and another place in Reading. The decision came down the pipe that he has chosen Reading. The other one has chosen Missouri over us. We have our recruitment firm that they've sent out another blast. We expect some more input, and we will continue this process moving forward. It's in a continual loop. So I will update the board regularly. Right now, there's really nothing there. Our PA Troxel is continuing to do field practice in the community, doing a great job. Her NRC scores. This is our public. This is the poll that we take out that goes out after the other visits. They've been very, very good, very complimentary. So we're really pleased there. Moving into information technology, several things are going here. Our IT managed services, I have penned and forgot to send a letter of intent to terminate our existing relationship with CSI. This was in consultation with TK, our director of IT. We're just not getting the support. It's a struggle with this organization. So I'm going to be looking at terminating that agreement with them. We do have another managed care or managed services IT team that is actually doing an assessment right now. And will be also offers these types of services that I think is going to be more comprehensive and much more customer focused for us. So I just want to let you know that we are looking to change the companies. It has not yet come to fruition, but that's what we're working on. The electronic health record evaluation. So just this week, we had our entire staff work through several demos with the Cerner Corporation. So this is the electronic health record that both PDH has and that Eastern Plymouth is seriously looking at. We are taking a look at it as well. The initial feedback without the survey results that come back was very, very positive. I think Steve had some questions around revenue cycle, some things that were unanswered, but I believe he's working to get those answers. But clinically, the feedback was excellent. It was a more comprehensive system. It was more integrated. It is on a single platform, which is very important, so that instead of modules bolted together, things flow through the system. So if a physician or a nurse making notes here, it flows through to the entire electronic health record for access. Instead of, it's not as kludgy. Very interested in the system. I've actually worked with the Cerner system for 4 years. I know it pretty well. But we wanted our staff to get out in front of it, and our physicians were invited also. And so far, the results were pretty favorable. We'll continue our due diligence, especially around the financial and total cost of ownership issues. But I will update the board more when we know.
Sean, it's Rich. We all know that Cerner and Epic are the two best systems out there. How can we afford it?
Well, there's two. Both of them have come forward with ways of dropping the costs associated with their electronic health record. They've taken two different methodologies. Epic has used what we call Epic Everywhere or Anywhere, and it is basically a bridge off of a host. So you actually have to. It's a cheaper version. It's for the community, but you have to have it hosted with another larger entity. For instance, Renown is Epic. So you have to actually create a relationship with Renown, which creates questions around autonomy. It creates questions about the control issues around our electronic health records sort of bridged off theirs. So it's designed that direction. So it's more of a relational concept or methodology. Cerner, on the other hand, has taken the Millennium, it's called Millennium, Cerner Millennium product that they've put out to all the large independent or integrated delivery networks and large systems. And they brought it down, they, if you will, condensed it down and distilled it down into a community version. So it's on the same platform with all the same services. It just is, it's just a smaller version. And they've done this because they see that the markets out there as it relates to the large players has diminished. It's pretty much almost all implemented. And the people that are kind of dangling out there with systems that meet meaningful use but aren't necessarily highly integrated and things like that are the smaller sites. So they've literally, from a methodology perspective, taken Millennium and distilled it down. It has all the tools, you know, the ones that I've looked at, has all the tool sets, has all the Millennium features, has the integration. It's just at a lower price point. So part of, Rich, what you're talking about is our total cost of ownership. Steve is working through our total cost of ownership of Evident currently today, and with the enhancements that we would need to bring it to the level of Cerner Basic. What's the total cost of ownership looking like? And we're doing that analysis now.
Is there any benefit in the Plumas County hospitals going together in this?
Yeah, I actually had conversations with the other CEOs. The community works, the Cerner Community Works isn't designed that way. It's not designed to manage multiple different entities. It's actually a smaller entity developed. So we had a conversation about, is there anything we can share? Anything that we can share around standard templates so that we have service, that we have maintenance. Like, TK, do you have something?
I was saying also, with it being, say, we all do go to Cerner, maybe not perhaps from the informational standpoint, but if you're talking about a district-wide registry where you're sharing resources of staff.
They're trained on it, they get it, yeah, things like that. We will not have a shared database though, Rich, I think is where you're going with that. That was decided that we will not have a shared database, but a similar system. I did, and I was able to talk to the other CEOs. The one thing that we all agree on is that we're not going to customize this thing to death. That's where we get in trouble with electronic health records. So really, if we're taking everything with what Cerner calls model experience, which is their right out of the box model experience, then we will, for the most part, be working off of very, very similar systems. So when we do that, if we have that ability to share some of those resources, it'll look very familiar to everybody.
Similar systems, and with us, if we were all participating with Cerner, it would be part of Commonwealth, which means the information from the other hospitals' visits will be.
That was my next question.
Flow into Commonwealth, as well as interfaces to our HIE, which we all the same HIE. There's a lot of advantages to it. You know, it's once again a fully integrated system versus an interfaced system is so much better.
Your experience with Cerner is probably like everyone else. You modify it heavily So you're saying that's not going to happen?
No, that's where things get sticky. I was in an organization that modified it and customized it to death.
Right.
And-
So does
and
everyone. Yeah.
it was very painful to maintain. The system out of the box for what we do here is quite good. But I understand when you're very complex, there's some system requirements that don't come out of the box. You want to do customization. But when you do that, you walk down the path of a lot of money and a lot of pain. The other piece to this is that it's not on-prem. And what I mean by that is not on premises. This is a software as a service. So it is like a subscription. It's like buying the Amazon cloud services or whatever. This is managed by professionals in their data center. So the system is managed, patched, upgraded, secured through their systems. The problem that we have with that and things that we're looking at is our internet, our reliability, our speeds. For us to use software as a service or cloud services relies upon a high-speed internet that is redundant, that is high speed, that is basically solid. So we are looking. I've actually asked TK just recently to look at what we call last mile vendors to see what it would cost us for Seneca to be an anchor client with gig fiber to our LAN. So real gig speeds into the hospital and with a redundancy built in. So lots of things going on there, trying to shore up our information technology.
And with that, Rich, we are looking for grants. to
Yeah, we're
implement.
seeking grants as well. And that kind of goes to number 3, which is the wide area network. We just talked about that. Software as a service requires a very solid and high-speed wide area network, and that's what we're working on with last mile. Any questions about information technology? Okay. Operations. So we Seneca has split the duties with one of our RNs. We all know Stephanie from our COVID days, right? She's in infection control. Stephanie is going to be taking on the role of nurse educator, a very critical, important position in the organization, as we need to train up our staff to higher levels of capabilities, higher levels of licensure, if you will, the ability to see things and create muscle memory. So there's a whole program that's going to be going into nurse education. It's not only going to be just a hit and miss, it's going to be a month after month after month of modules of training. This nurse educator is also going to be incorporating more code drills so that we get our muscle memory built back as it relates to our codes. So we're pretty excited about that. That's happening now as we speak. We are evaluating a sleep center. So we were approached by an organization that has sleep physicians. They are a accredited sleep center. They do this in critical access hospitals. This is one thing that we don't have in the basin is a way to diagnose and deal with sleep disorders, which we have quite a few. There's lots of comorbidities associated with this. So we were presented, this company called Newport Health has presented, to us as it relates to developing a sleep center. This would both be outpatient and inpatient. So we'd actually have a place to do sleep studies on site that would be overseen by a physician that is a sleep expert. We are taking a look at it. We have to look at a lot of the professional services agreement contract language. We have to look at costs and such, but I wanted to share with the board that that is something that I'm personally interested in. I think it would be a great addition here. This would also lead to durable medical equipment. So DME around CPAP devices and ortho work and things like that. Our dentists, our new dentists here are very much into orthodonture sleep mechanisms. So, we're going to take a look at this with that very discerning eye, see if it's something we want to do. Okay. MRI mobile services. I met with Alliance Imaging around our mobile MRI services, around the getting rid of the generator, moving to land to our power, a different power source, which we are going to bring to the board for approval probably next month. We have quotes to bring in power. I asked them to do some enhancements to their MRI. This MRI travels Eastern Plymouth, PDH, us, and then down over the hill to Reading. It's a good machine. It's a good machine. 16 channel. It's 28X, so it's got lit software. It's a good machine. I did ask them if they could potentially put in our route a whiteboard. You know, people get nervous about MRIs. It's claustrophobic a little bit, and we want to ease that pain. So there's a whiteboard option out there. So they're going to look into possibly putting into service a whiteboard through our route. The other thing I asked for was music. You know, when you're in there, is there a way to develop and provide the patient with music so it takes their mind off what's going on? They're quite noisy sometimes, so they're looking into that for us as well. Our volumes have been pretty stable. I think that once again, our medical staff understanding that this mobile MRI, while it's in a trailer, is as good as anything you'll get in the valley is really important. The technology is excellent. The quality of the images is excellent. The technology is excellent. It's just in a trailer. So we want to kind of overcome that with the community and our physicians, although our physicians are using it more and more. So it's still every 2 weeks, we probably won't go off of that. But then again, MRI is not, other than a couple of things like spinal cord compression, things like, it's not an emergency. Generally, it's usually outpatient stuff. Anyway, mobile services, I'm working with the company to really promote it and really move it along. Okay. Any questions about those operational items?
Question?
I don't think so.
No.
Okay, last one, marketing and public relations. I mentioned the town hall on June 7th. That'll be at 5 in the old theater. We're inviting everybody. It will also be Facebook Live and Zoom. For those who cannot attend, we will be featured.
Sean, did you?
And branding continues. Go ahead, Ken.
No, you cut out just for a half a second, so go ahead.
Okay, our rebranding continues. So Seneca will be issuing a press release announcing our new branding and logo the first week in June. Our new badges now, we have a new badge machine and it's printing. They're printing as fast as they can. So as we rebadge, we are going to send a press release out about our new branding, our new look. So that's all going forward. New signage is coming out. All of our print materials, our media, our digital media materials are all being changed over now. So I just want to update that is a continued effort. And when we see the old logo, we get after it, we change it because it's everywhere. You just don't realize it, where it is. The health fair, Seneca Health is planning to bring back our annual health fair and community wellness screening on June 23rd and 24th and June 30th and July 1st, 7 a.m. to 9:30. There is an attachment in for the board members. This is something that the community really misses and we're bringing it back. So I'm glad that we're emerging from COVID and starting to get back to some semblance of the July 4th, we are going to be featuring a Seneca float. I want you to know that our first float meeting was excellent. We have some pretty great ideas. So that team is moving forward. We will have a float in the parade. It is going to be themed with our new logo. It's going to be themed with our new commitment to our community. It's going to be a lot of fun. We're working on that, just want you to know. We are also, the VRBO and property managers brochures are being completed. Those are going to every packet throughout the rentals, all around the basin, Clear Lake, Westwood, Pinetown, everywhere. They're going to be going out, as well as I've asked Chelsea to take a look at a mailer for the people that are either full-time residents here or not VRBO, but renter, but people that have second homes up here, so mailer, to just talk about what our services are. What is our brand? What are we doing? What's our recommitment? So there's a lot of things going on in the marketing and PR world. All right, I'll take questions. What's happening?
Everybody's really busy.
It's busy.
Okay. Last chance for questions. Thank you, Sean. Appreciate the report. You're right, a lot of moving parts. That takes us to item number 13 on our agenda. We had departmental reports. We had a report submitted by Chelsea on compliance and on the clinic and telemedicine, and from Jim Kooiman on human resources. Wondering if board members have any questions on those reports that were submitted.
No questions, just thank you to the folks for putting those together. It's very helpful for us.
Okay. No other questions? We will move on. As Jerry said, thank you for submitting those reports. And for item 14, what do we need to add to next month's agenda?
We're gonna be probably approving the budget, right? We're gonna review it at the strategic planning, or are we gonna approve the budget I'm sorry, not strategic planning, the special board meeting that we're gonna have, or are we gonna approve it at our regular meeting?
Steve, Sean, can you speak to that?
I'd rather Steve speak to it, but my understanding is that during the special board meeting, we are going to be laying out the 2021-22 budget, take questions, massage it, and then
And then bring it
Steve,
back.
help me out. I think we're going to bring it back to the board in June for approval.
I think that makes sense. So we would want that for our
Next board meeting. I didn't hear.
Yeah,
Steve.
hi, sorry. We can put it on the agenda for approval, and if we have a quorum and you guys are good with it, we can approve it. Otherwise, we'll just kick it to the month-end meeting.
We can approve it at the first meeting. I thought I heard something different, that we would just discuss.
Ken, I would recommend that after discussing it, the board members have time to think about it and then come back to the regular meeting and approve it. I don't think 2 weeks in approving the budget is going to make much difference.
That actually makes sense to me as well. Anyone else?
I agree.
Okay, so we will discuss, think about it, and put it on our regular calendar meeting for June.
Did we also want the policies and procedures 5 and 6? Jerry, were you wanting to do that?
Yes, yes, thank you.
Okay. All right, made my notes here. Let's then, looks like we're gonna move to the closed agenda. Closed session agenda. So Jerry, can you communicate with TK for us? We'll ask her to limit the participants to board members and just you, Sean, I'm assuming.
Yes, we have QA. She'll be coming, like Heather will be coming in. You'll admit her when we get there, okay?
Sean, I probably didn't get that. Just you in the closed session?
It's just myself until Heather is going to be coming in to talk to you about QAPI in closed session, and we'll admit her. Do we want to do her first?
I don't say, your pleasure.
Yeah, want to admit her, give her a call.
Sure. Ken, I'm going to pause recording in just a moment here, and we will have to join a closed session to begin with.
Sounds great, thank you.
Okay.
Okay. Okay, welcome back to the open session. The closed session has concluded, and there was no reportable action taken by the board. It was just information only. And that takes us to our last agenda item, which is item number 17. Our next regular meeting will be on June 24th at 3 p.m. And we will meet, we can meet in person in the boardroom. Folks can also attend via Zoom. Okay, well, thank you, everyone. Have a good week, month till we see you again. Okay,
Take care.
bye-bye all.
Bye.